Hello and welcome to Sleep Review's webinar, Pulling Back the Curtain on AI in Sleep Medicine. Sleep Review is pleased to be here with three esteemed presenters, Nate Watson, MD, MSc, Jan Augustin, PhD, and Emmanuel Mignot, MD, PhD. After the presentations, we'll answer your questions. Submit questions anytime via the Q&A box on your screen. We also have the advanced questions submitted on the webinar registration screen. So when we get to the Q&A segment, we'll lead with those. The slide deck is available for PDF download in the handout section of your control panel. Also in the handout section is a resources handout, which includes peer-reviewed studies and links to other resources that may be of interest. This program is brought to you by Enso Data and Knox Medical. For a certificate of attendance, which is available for the live webinar only, you must meet a few criteria. You must watch the webinar on its original air date of May 28th at about 11 a.m. Pacific time for at least 60 minutes. You must complete the course evaluation, which will appear on your screen at the end of the webinar or when you personally leave the event, whichever is earlier. Even if you don't have a need for a certificate, we'd appreciate it if you'd give us your feedback via the evaluation. If you're watching as a team, you need to register separately now if every team member wants their own certificate. Everyone who meets these criteria will receive a certificate in their email within the next 30 days. For AAST members only, we will also submit your one continuing education credit directly to AAST. If you do not get a certificate within 30 days and you think you met the criteria, you can email sroy@medcore.com. Today's webinar is being recorded and you will receive an email tomorrow with a link to the recording. It will also be available for new registrants to watch on GoToWebinar for the next 3 months. I am now pleased to introduce Nate Watson, MD, MSc, who is Professor of Neurology, Co-Director of the Sleep Center at the University of Washington, and Director of the Harborview Medical Center Sleep Clinic in Seattle, Washington. He is the former President of the American Academy of Sleep Medicine and the American Board of Sleep Medicine. Dr. Watson has had multiple research grants to study sleep disturbances and has published extensively for medical and lay audiences. His current investigations include the relationship between sleep-disordered breathing and cancer risk and the impact of artificial intelligence and consumer sleep technology on human sleep and sleep medicine. Welcome, Dr. Watson.
Yes, thank you very much, Sri, for that wonderful introduction. And it's my pleasure to be here today to speak with you on this very interesting topic. So wherever you are, good morning, good afternoon. I suppose we're probably spread all over the country, but again, it's my distinct pleasure to speak with you today. So, up front here, I just want to make it clear to everybody that there is no relation between me and the IBM Watson supercomputer, although, there might be a little bit of a resemblance there. But in all seriousness, I'm an advisory board member of SleepScore Labs and SleepScore Ventures. So today, I'm going to give you kind of a broad overview of sleep medicine and AI, and we're going to try to read some tea leaves and think about the way that this might transform sleep medicine going forward, and kind of, what this means generally for us in our field. I'm not going to tell you how you should feel about it, but I will challenge you to think about it, and hopefully I will, raise a number of questions in your mind about how this will alter and change our field. Okay. So, we live in a world in healthcare where we're awash in digital data, and right now we probably do about up to 25 million sleep-wake EEGs in the United States, where we're trying to assess diseases such as epilepsy or perhaps neurodegenerative disease. We also do about 4 million polysomnograms that we're all very familiar with. And we visually assess this data, and we use our scoring rules, and we've been successful at doing that for years. But I think what we're beginning to realize that artificial intelligence is showing us, which is quite honestly the fact that there are time and frequency domain elements to the EEG that we just can't see with our eyes. And so this is akin to this picture right here. What you may appreciate is that this does appear to be, kind of a rainforest photo. You can see a lot of moss, there's trees, there's ferns. This would be maybe us just looking at the EEG. But if you look more carefully, you can begin to see other things here. So this is a tree sloth right here. This looks like a jaguar to me. Over here we have elephant, an orangutan here, and then a panther over here. And there's probably other things in this picture that I haven't appreciated yet, despite the fact that I've actually looked at this picture a number of times. So I think, that's kind of our current situation right now. There are these other elements lurking in the data that we haven't seen for decades, and now we're beginning to appreciate these things. We have to understand that the PSG represents a dynamic multivariate human physiological state. And so, we have our 3.2 billion DNA base pairs, which, are mostly static, although, epigenetic modification or post-translational modification of proteins or telomere shortening. I mean, there are things that can happen that can influence DNA or its products, but it's mostly static. And our DNA doesn't tell us anything about our environmental exposures, such as whether we've been exposed to toxic water, we've been injured in a fall or had a brain injury, or got on some new medications. And so the point being that, our physiologic state is incredibly complicated. And by some estimates, your state contains roughly 1 million trillion times more information than resides in your genetic code. So this defines the complexity of AI. Really, the problems that AI is going to try to solve has to take all of these things into consideration. Okay. One last thing is that the EEG is a measure of the current physiologic state of your brain. Okay. So, there's a lot of talk about machine learning, polysomnography, scoring, and there are a number of studies that basically show that this is reasonably accurate. Here is one right here on a fairly smaller scale. It was in 50 individuals, and what I'd like you to appreciate is that you have manual score 1 and 2, and then you have your AI score algorithms 1 and 2 as well. And this figure here is comparing all of these individuals to each other. And on the y-axis, we have an F measure, which is essentially an assessment of both the precision and sensitivity of the ability to determine these various sleep stages. And what you can see is that in general, there's good correlation between both individual human scores and the AI scoring that's done. N1 is a little bit of a challenge, as we all know, determining N1 from wake, but in general, things look pretty good here, suggesting that, accuracy is not necessarily going to be problematic with machine learning polysomnography scoring. Now, Biswal took this a step further and looked at not only sleep staging, but also apnea detection, AHI categorization, and limb movements. And limb movements essentially are over here on the far right. So for sleep staging, what we can have is this confusion matrix, which shows the human scoring versus the prediction. And you can see here along the diagonal that there's really strong agreement between both for all of these stages, with the exception of N1, where it reduces a bit. So agreement is 0.85 or greater for all these other sleep stages. If we look at apnea detection, you can see that you have the predicted AHI versus the true AHI, and you have a fairly high correlation. If you look at AHI categorization into various levels of severity, you can see, again, there's a pretty high agreement of 0.74 or higher for all levels of sleep apnea. It drops a little bit here around the issue of determining AHIs above or below 5, but still showing reasonable accuracy. And then for limb movement detection, again, there's a pretty good correlation between the human and the AI determination of these events. So moving beyond just polysomnography scoring, what if we just focused on the EEG? And the question would be, can you estimate OSA severity just by using the EEG? And this study was done by Chris Fernandez and his group at Enso Data, where they looked at over 4,500 PSGs. They just looked at the EEG element there. They were looking at local phenotypic features that were derived by analyzing biomarker patterns and respiratory cycle related EEG changes that would be exhibited in EEG signals directly. They used a bidirectional long short-term memory and deep convolutional neural network approaches here, and basically wanted to assess how well they were able to determine OSA severity greater than or equal to 15. So here, what you can see at the top is a hypnogram. 4 over here on the side on the y-axis is REM. Then we have N3, N2, N1, and wake. You can see it's a reasonably normal hypnogram. Here we have the arousals per epoch, and down here are respiratory cycle-related EEG changes that are pretty minimal. And so this individual is at low risk for having OSA or an AHI less than 15. On the other hand here, this is a high-risk individual for having an AHI greater than 15. Again, we have the hypnogram at the top. We can see more arousals per epoch here, and then we also see more respiratory cycle-related EEG changes down here. And what we end up with here is these receiver operating characteristic curves, excuse me, where we have basically the sensitivity plotted versus 1 minus the specificity. Here, for the most accurate test, you want to have the largest area under the curve possible. And, what they found here was a combination of those two machine learning models that revealed a sensitivity of 86.9%, a specificity just shy of 100%, and an accuracy of 91.1%. So showing that just with the EEG, you can get a reasonable assessment of OSA, the presence of OSA with an AHI greater than 15. And I find this somewhat ironic in the sense that we've been going through a time of diagnostic reductionism for the past 10 years or so with home sleep apnea testing, where we've de-emphasized the importance of the EEG. And now, as artificial intelligence comes along, it's beginning to show us that perhaps the EEG is the most important element of what we collect on a sleep study. And so it'll be interesting to see how this evolves going forward. Also, just looking at the EEG, there's some research that's evolving showing that brain age can actually be predicted by this. And so, brain age is a potential aging biomarker. And so essentially you're looking at an assessment of a person's brain age in comparison to their chronological age. Previous MRI-based studies have shown a number of neurological and other diseases are associated with accelerated brain age. And so Sun and his group used a machine learning model to try to predict brain age from these large EEG data sets. So it's over about 4,500 EEGs altogether that were utilized here. And in this figure on the left, so we have brain age on the y-axis, chronological age on the x-axis. The red dotted line would be when these two things are exactly the same. Here on the left is if we were to assess just sleep macro architecture as a biomarker, and you can see that you get a mean age difference that's very high at 23.3 years and a lower correlation. However, on the right, if you begin to look at sleep microstructure, or the things that really AI can get into, you can see the mean age difference improves quite a bit, and as does the correlation as well. And so here on this slide, across the rows, so here at the top are younger individuals, middle-aged individuals, and at the bottom you have older individuals. This is also a confusion matrix, and so here on the diagonal we see individuals where their chronological age and brain age line up pretty well. Over here on the left, these individuals are in the fortunate situation where their brain age is less than their chronological age. And then on the right, we see individuals where the opposite is in effect, where unfortunately their brain age is older than their chronological age. So, what you can see here on the top right is that, a lot of things that we think would drive this and that we measure in sleep really do. So, the amount of time that you're in N3 sleep, or your N3 percentage, or your sleep efficiency, or total sleep time, does correlate with this, and does drive a lot of these associations. And what you can see here as well is that in the healthier individuals, you can see fairly tight and robust sleep spindle activity in stage N2 sleep and spindle density. Whereas in the individuals with older brain age, you don't see the same kind of spindle density. So, this is interesting because it could allow us to have a preclinical marker of brain health to allow us to intervene. Let's say, in the future, if we have neuroprotective agents, this also may allow us to use the EEG as a way to assess brain health over time and to assess the impact of interventions on brain health. And lastly, in regards to this issue here, we have this figure where you have the probability on the y-axis and the brain age index, which is brain age minus chronological age, on the x-axis. On the left, we have in pink, in this histogram, those that had significant neurological or psychiatric disease compared to those that didn't. And you can see that the brain age index is increased by about 4 years if you had these diseases. On the right, we're looking at people with hypertension and diabetes compared to those without those diseases, and you can see that this shifts the curve to the right about 3.5 years. So just kind of proof of concept that you would expect people that have these chronic diseases to have to show an older brain age index, and that's indeed what they found. Okay, so now that we've kind of touched on those elements, let's go through this notion of thinking about it and what it means for sleep medicine, for medicine in general, and really for us as members of society. So I couldn't help myself, but I had to put a slide in here of Neo from The Matrix. And early in that movie, he's presented with an option to swallow the red pill or the blue pill. The red pill will show him the truth. The blue pill will put him back into his blissful ignorance about his situation. I think AI is presenting this type of question to the sleep community. We know that we don't have enough board-certified sleep doctors to take care of all the sleep disease that's out there in the world. I mean, 70 million people in the U.S. have a sleep issue. 60% of them have a sleep disorder. There's one board-certified sleep doctor for every 45,000 citizens. And so, there's no doubt that we need to increase access to diagnostic and treatment, diagnostic modalities and treatment modalities for individuals that right now just aren't getting taken care of. So, I'm going to suggest we swallow the red pill and move forward here with what this technology can do for us. I was also thinking a bit about this notion of phenotypic determinism, and let me just walk you through this. So the genotype, is the genetic constitution of a person. The environment is all the external physical, chemical, and biological factors that would help define who you are and who you become. So the phenotype is kind of that gene-environment interaction and who you end up being. Now, we've lived in a time of genetic determinism for a while where we have this sense that genes really define who you are and what you're going to become. And and just putting increased emphasis on genetics. And you overlay that on top of a time where we're also living in a time of the quantified self, where people want to be able to measure themselves and understand themselves longitudinally from a lot of different perspectives. We know consumer sleep technologies are out there that people are utilizing to understand their sleep better in an ecologically valid manner. So my concern is phenotypic determinism through AI. I mean, once AI gets to a point where it can integrate everything, all the omics, genomics, transcriptomics, metabolomics, along with all various environmental factors that could be out there, elements of the quantified self, and put all of these things together, it's possible that, for instance, it could identify people that would be at higher risk of, let's say, developing cancer if they had a shift work schedule. But shift work may provide a higher salary. Well, you could be an individual that ends up being prevented from having the opportunity to work or making a choice for themselves about what they wanted to do because of this risk identification. So I think that there are questions that we need to ask and things that we need to think about here as far as the impact that this may have on society going forward. From a medicine perspective, I think it may well take us back to the future. Here's a picture of Norman Rockwell. He's leaning in, he's engaged, he's talking with the concerned parents of this child, making good eye contact and really present and listening and providing the comfort that is so important in a clinic visit. Compare that to where we are now, where we're oftentimes typing notes or while we're trying to talk to people. We're not looking at them. We're having to deal with prior authorization and insurance companies and all these other issues in order to get testing done. It becomes a distraction between the doctor-patient relationship. Well, I could see AI changing that for the better in the future. I mean, imagine a clinic room where you go in, you're engaged, you're having a conversation with the patient. As the conversation occurs, your note is being auto-generated, and you have a disease probability index that's coming up that can change in real time as the conversation and physical exam proceeds. And then at the end of the visit, help you not only finish your note, make sure that all the required elements from payers are in there, but also, recommend and help you order the appropriate tests. I see this as being a real plus as we consider the impact this will have on us going forward. A couple other slides here. One, I need to point this out. The American Academy of Sleep Medicine did release a position statement on this very topic. I would encourage you to read it, but the main findings are here. That they say while AI applications that score sleep and associated events are expected to improve sleep laboratory efficiency and yield greater clinical insights, the goal of AI integration should be to augment, not replace, expert evaluation of sleep data. And then, over here on the right, really talking about the big plus, which is this notion of subphenotyping or endotyping patients. So, we don't just view sleep apnea as one monolithic disease, but we understand that each patient is unique and that we're able to address that uniqueness in order to tailor therapies in order to increase and maximize efficacy of treatment and positive outcomes. So in summary here today, we talked a little bit about AI and sleep study scoring. The entities that are out there doing it now continue to recognize the importance of a skilled technologist reviewing the AI scored study, and that's also the position of the American Academy of Sleep Medicine right now. So that's important. We looked at the EEG and OSA severity estimation, suggesting maybe the EEG is perhaps the most important part of the sleep study now. We talked a bit about brain age and AI, and then AI implications for the future of healthcare. And with that, I'll leave you with this final slide, which includes, some of my favorite movies related to artificial intelligence that you can perhaps watch if you haven't seen them already. Thank you very much for your attention.
Thank you very much, Dr. Watson, for an excellent presentation. I see that several questions came in during his presentation. We will be answering those at the end, so you are welcome to submit your questions anytime using the Q&A box on your GoToWebinar control panel. Before our next presentation, we have a quick word from sponsor Enso Data. Enso Sleep is a sleep scoring AI system that is saving sleep centers around the country both time and money. Enso Data's flagship product is not only improving the quality and efficiency of sleep testing services at over 300 partner locations, but it's also analyzing 14,000 sleep studies per month in just 25% of the time it takes to be done manually. Taking the next step is as easy as a 30-minute demo with the Enso Data team. Shift from a manual scoring process and start focusing on scaling your sleep enterprise with the help of AI. Now, I am happy to introduce Jan Augustin, PhD, who holds a master's degree in electrical engineering from the University of Iceland and a PhD in physics from Basel University in Switzerland. During his training and career, Dr. Augustin has focused on metrology, the science of measurements, and data science. He is a research manager at Knox Research, leading a team focused on developing novel methods of analyzing data recorded during a sleep study. Knox Research is an interdisciplinary team of scientists working on advancing sleep medicine by collaborating with medical scientists, doctors, and other sleep researchers. The scientists at Knox Research have a strong background in AI, data science, and engineering. Furthermore, they have a deep interest in physiology and sleep medicine. This allows the team to communicate with sleep researchers and help build bridges between medicine and engineering. Welcome, Dr. Augustin.
Thank you, and thank you very much for having me. So, do you see my slides now? Yes, okay. So I just thank you very much for organizing this event. I think it's very important to have exactly this kind of event where we have doctors and scientists and engineers coming together and talking about technology in sleep medicine. I just want to catch the ball where Nate Watson left it in the air about talking about that AI will probably not replace the doctors, and I fully agree with this. And the way we like to think about it is we want to make AI boosted doctors. So I just want to start by see. There's something. Here we go. Okay, so I want to talk about some things which are good to have in mind when you're thinking about automatic analysis to processing your sleep data. So I first of all want to point you towards this paper which was recently published in the Journal of the American Medical Association titled "How to Read Articles That Use Machine Learning." I think it's a very nice paper, and it's written for doctors and clinicians who are likely to be using machine learning-based analysis without being experts in computer science or engineering. And it's very important for anyone who's using these tools to be aware of their capabilities and their limitations. And if this reference is the only thing you take away from a presentation, I'm completely happy with it. So there's a lot of hype about AI, machine learning, and big data, but there's no clear definition of what these words mean. So typically, AI and machine learning are used to describe models where the model parameters are tuned to by fitting known input to some known output. So for example, linear regression is a perfect example of such a model, although more complicated models such as artificial neural networks get much more attention today. And AI models, they are not intelligent in any way, but they can recognize very complicated patterns and map them onto an output. An example of this could be a deep learning model trained to classify images as having either a cat or a dog on them. And if you give such a model a picture of a bird, the model is only capable of classifying the image as having either a cat or a dog on it, and the model cannot deduce that the bird is neither a cat nor a dog. And let's look a little bit at the difference between conventional programming and machine learning. So in conventional programming, a programmer enters rules or a program into a computer. And these rules are used to process data to generate an answer. And the rules, they can be arbitrarily complicated, but they are generated by the programmer and can, in principle, be understood by a human. In contrast, machine learning, whether it's linear regression or more sophisticated models, is typically based on using an algorithm to infer rules by presenting it with data and answers. And this is called supervised learning. And this can be a very powerful approach when it's difficult to write the rules or if the rules are unknown. And if we stick with the example of classifying images as having either a cat or a dog on them, you can imagine having a friend who lives on a different planet and doesn't know cats and dogs. And now if you have the task of writing a letter describing how cats and dogs look like, and then sending him pictures for him to label cats and dogs, you can imagine that's almost impossible. It would surely just be much simpler to have a bunch of pictures with cats and dogs on them and write on the back if the picture has a cat or a dog and send them the labeled pictures to learn. And this is what we do in supervised learning. And once we have the model we trust, we want to use the model to predict answers on new data where we don't have the answers. In case of our alien friend, we would now send stacks of photos with pictures of cats and dogs and ask him to label them for us. So the fundamental idea behind machine learning is not very foreign. And even though the technical implementation of machine learning can be mind-boggling, we currently have tools such as Python and TensorFlow and more, which allow basically anyone to do machine learning. And even if you only know basic programming, you can take the Coursera specialization AI in medicine, and you can be detecting tumors from 3D MRI scans in a matter of days. And even if you're not into programming, I would still recommend watching these lectures because they touch on a lot of the topics which I'm going to be talking about today. But since machine learning is so accessible, what separates the good from the great? I think in my opinion, what separates us is that we need to have a very deep understanding of the tools that we're using. We need to understand the subject matter. We need to understand the data, the signals, and the questions we want to answer. And we also need to understand how our models are going to be used in real life. And at Knox Research, we are a multidisciplinary team with a background in engineering, computer science, physics, statistics, and sleep medicine. And one of our main areas of expertise is to use machine learning to automate manual scoring and to develop novel analysis to apply to the studies. So for the remainder of the presentation, I want to share with you some of our work. And since we're here among friends, I will even share with you some of our mistakes and challenges we've had to face. So let's start with sleep staging. I always tell people that sleep staging is the homework example of using machine learning in sleep medicine. In our field, I think this is the easiest thing you can do with machine learning. It's not because it's easy, but because the task is so well defined. So we know that we have to classify each 30-second epoch into one of 5 classes. We know what signals to use. Human experts, they generally agree on sleep scoring. There's an abundance of well-scored data available, and there are many papers comparing how human experts agree, so we even know how to measure success and what kind of an agreement we should expect at maximum. And after defining the goal, we have to collect the data. And the critical thing is that data should represent the data that we expect our model to be used on in the future. And when I started at Knox Medical 5 years ago, we had a machine learning algorithm for classifying sleep stages. But the problem with this algorithm was that it was trained on data from people with severe sleep apnea. And these people did not have much N3 or REM sleep, so the model couldn't learn how to score those sleep stages. It scored almost every epoch as N2. So the first machine learning task that we did in our group was actually to update the model to the one that we have today. And when we have good data, we have to split it into a training data set and a hidden test set. When making the split, it's very important that we don't have data from the training set in the hidden test set, because when we do the final validation of the model, this could lead to an overly optimistic result. Then the training data set is further split into training and validation sets, and these are the data sets that we use when we're developing our models. And during the development of a machine learning model, we may easily test tens or hundreds of models. So it's common that we get a false positive response. And this is why we have the hidden test set. So once we have a model that we trust, we can test it on data that is never seen before and see if it actually works. However, the true test of the model comes when people start using it in the real world. And a good place to start when you're developing a model is to look at the state of the art. And for sleep stage scoring, we have the ASM manual. It tells us exactly what we need to do to score sleep stages. The ASM manual tells us what signals to use and what to look for in the signals, such as spindles or K complexes. But anyone who has scored a sleep study knows that reading the manual is not enough. You need a lot of practice. And this is exactly the reason why we cannot just take the ASM manual and write a program from it, but we need to train a model to do the scoring. And a simple place to start is to use feature-based artificial neural networks. We can use the ASM guidelines to determine which features in the signals are of importance. And these could be delta power, signal amplitude, or whatever we can think of. And then we feed these features into a neural network. The neural network is comprised of nodes, where each node in one layer is connected to every node in the following layer. And the network starts with an input layer where we insert the features. And then we have several hidden layers, and we have a classification layer at the end, and the last node chooses the classification result with the highest value and outputs it. The nodes in the layer are normally performing just linear or logistic regressions. So actually the fundamental building blocks are very simple. And since sleep states of an epoch may also depend on what came before it, we can also change the last layer before the classification to a layer which uses what happened in the past to improve the prediction. And this would be the LSTM networks that Watson was talking about before. And these are also called recurrent neural networks. And these are used, for example, in language processing and other cases where the context matters. Or we could use also convolutional layers or convolutional neural networks, and then we just have enough data that we can actually have the neural network learn what are the important features. And we don't have to manually enter the features. And the nice thing about sleep staging is that we know how well human experts agree. The ASM Interscorer Reliability Program published a paper in 2013 comparing how human experts agree on sleep state scoring. And the results are presented in a confusion matrix where each row represents the sleep state scoring of the majority of the scorers, and the columns compare how the individual scorers agreed to the majority. So for example, we see how they agree on the sleep status on the diagonal, and we also see what kind of mistakes they're likely to make. For example, if we look at sleep states N3, it's common that it's misclassified as sleep state N2, and it's very rare that N3 is misclassified as wake. If we have a very good machine learning model, we would predict that they would behave similarly. We can compare the results from our model to this human benchmark, and what we see is that exactly we have this high degree of agreement on the diagonal, and also the types of mistakes the model is making are similar to the types of mistakes the humans are making. So for example, for N3, most of the misclassifications go into N2, and it's very rare that we misclassify sleep state as wake. So once we've gained confidence, there was one more thing. There's also one thing with the EEG that we can do, and this is actually we can look at the raw data to verify if the model is correct or not. And I think this is very important to build trust in the AI models, is that you can actually go back and look at the raw data and see what they're doing. But once you have gained confidence in detecting sleep from EEG signals, why not applying the same methodology to non-EEG signals? So for example, pulse or actigraphy or something like this. But first off, at the risk of sounding like the ASM police, sleep stages are defined by what's happening in EEG signals. So I think if we want to talk about sleep stages, we have to be measuring EEG. However, we know that there are a lot of things in the body which change during sleep. So for example, people typically don't sleep standing up. We know that movement goes down, pulse goes down. So there's a lot of things that we can use. And there are differences between wake, REM, and non-REM that we can pick up. So we developed an algorithm that we call the NOx body sleep, which uses the abdomen and thorax rip signals and actigraphy to estimate wake, non-REM, and REM periods. And here we have 2 epochs of manually scored EEG signals on top from a PhD study. And below we have the actigraphy and rip signals in a bit larger time period. And we have the manual scoring from the PhD on top, and then the result of the body sleep is shown below. And what we see during the non-REM period, that breathing is very stable, and then in the REM period, it becomes very unstable. And I think people who are used to scoring sleep studies are quite familiar with how different states of sleep present themselves in the breathing signals. From the body sleep algorithm, we can compose sort of a hypnogram. And here we see the hypnogram from the manually scored PhD study before, and the result from the body sleep. But one thing to keep in mind, that since that we're using the RIP signals and the actigraphy in the body sleep, there are no established rules that allow us to go back to the raw data and verify if the outcome is correct or not. And so I think this is going to be a very big topic in machine learning in medicine, actually, is to find ways that doctors can actually ask the model, why did you come to this conclusion? And I think there was a paper from Emmanuel Mignot which has a very nice solution to this, like a pretty good solution to this, and we're using this in the body sleep. And this is what they call the hypnodensity plot. And the hypnodensity plot is actually showing us the output of the neural network for all the sleep states. And now we can see if there is uncertainty in the prediction, then maybe the model is a bit uncertain, and we can direct people to go into these areas and look at the data more closely. And since the original paper was for narcolepsy, I just want to mention that the body sleep was developed to improve the estimation of sleep time in sleep apnea, and has not been validated for scoring sleep stages in patients with highly abnormal sleep profiles like narcolepsy. And this goes back to having the validation done on the data that you are hoping to use it for. Now I want to switch gears and talk about something totally different, and this is arousal detection. And I think developing a machine learning analysis to score arousals is very difficult. And there are several reasons why it's very difficult. First of all, arousals are very rare. So assuming that you have a patient with an arousal index of 10, and the average duration of arousals is 6 seconds, then for 1 hour, you will have 60 seconds of arousal time, or 1.7% of the total time. And arousals, they can occur at any time during the sleep study. So in contrast with the sleep staging, where you have to classify each 30-second epoch. Furthermore, human experts often don't agree when an arousal has occurred. And when they score arousals, they are often not very accurate with the start and the end points of the arousal scoring. So if you look back at this ASM interscorer reliability paper, we can see how they evaluated the agreement of arousal scoring. And the paper states that the scorers was asked to report the number of arousals within a given epoch. And if we use this criteria to evaluate our machine learning algorithm, the result for the performance would be the same if we score an arousal like here, labeled number 1, or if we score a single arousal across the whole epoch, labeled number 2, or if we score a short arousal in the beginning of the epoch, labeled number 3. But I know that if I develop a machine learning model which is scoring like number 2 or number 3, people would not trust it and they will surely not use it. So we had to come up with a new way of defining our performance, and what we did was much stricter. So we split the 30-second window into 1-second intervals. And then we label these 1-second intervals as normal, where there's no arousal scored, or arousal where the arousal was scored. Then we had our machine learning algorithm score arousals, and then we counted the true negatives, the false positives, the false negatives, and true negatives. And we see here that in the beginning, when there are no manually scored arousals, we get all true negatives because we don't score any arousals. We see that when our machine learning algorithm scores the arousal and it overlaps with a manually scored arousal, we have true positives. And then where we were scoring an arousal and the manual scoring was not scoring an arousal, we get false positives. And in this case, it's probably because the arousal scoring from the manual was not totally accurate. And then we can take these numbers and we can calculate some kind of performance metric. And I just want to talk about accuracy because I see accuracy being used a lot, and it's often not a very appropriate metric. So if we take our true positives, so we had 5 in this case, true negatives 21, false positives 4, and false negatives 0, and we calculate the accuracy, we get an accuracy of 87%. It's not bad. But now let's think about what is the accuracy that we would get if we would score no arousal in the epoch. So if we score no arousal in the epoch, we get 25 true negatives because there are 25 1-second periods where no manual arousal was scored. We get no true positives because we don't score anything. We get no false positives, again, because we don't score anything. And we get 5 false negatives because there are 5 1-second periods which were scored with an arousal. We plug this into the accuracy equation and we get 83% accuracy from our algorithm. So now we see that the accuracy is not a very good metric for this. And this was something we really struggled with to find what is a good metric to measure the performance of our arousal scoring. So in the sleep conference last year, we opted to compare the intra-class correlation of the arousal index we got. And this is not great. It's similar to what the ASM interscorer reliability paper was doing, because the arousal index doesn't tell us where the arousals occur within the sleep study. But I like using a metric called the F1 score. And this is same as the F statistic that Watson was talking about earlier. It's a similar to accuracy, but it doesn't take into account the true negatives. So now we can calculate the F1 score for these two examples we had before. And we see in the first example where we were scoring the arousal, we would get an F1 score of 0.71. And if we score no arousals, we would get an F1 score of 0. So it's actually a much better performance indicator for this. But the problem here, and there are other metrics we could use, but the problem here is that there are no papers which are measuring the performance of or the expert agreement using these metrics or other metrics which are more suitable. So we don't have a benchmark of how well our algorithm is performing compared to human experts. There is one thing that we could also do, or that we also did to kind of prove to ourselves that we had a good arousal classifier, is that actually in 2018, Physionet hosted a competition of classifying arousals from EEG data. And our interns participated and ended up in second place against very stiff competition from academia and even companies in the sleep industry. So we know that at least compared to the others, we're doing pretty good with it. Anyway, what I want you to take home from this is that when you're using machine learning models to process your data, it's worth thinking about, does the validation data for the model reflect the patients that you are using the algorithm for? And also you can think about, can you verify the output of the analysis? And if you cannot do it, is there something that you can do to help you build trust in the analysis outcomes? And maybe last, do the metrics, validation metrics make sense? So you can think about, like in the accuracy example, what happens if you do nothing? What would the results be? And do the metrics measure what matters to you? So for example, in the arousal case, if the metric is just measuring how many arousals occur in the sleep study, but not where they occur, then maybe this is not a good metric for what we want to do. And again, I just want to point you to this paper. I think it's very nice, and thank you very much.
Thank you, Dr. Augustin, for sharing your presentation, including sharing some of the challenges that you faced in your research. Now, a word from sponsor Knox Medical.
I'm in love with you. Why am I love? I'm sending out. I'm in love with you. Why am I love? I'm sending out.
Okay, thank you for that word from Knox Medical. Now I am happy to introduce Emmanuel Mignot, MD, PhD, As director of the Center for Sleep Sciences and Medicine at Stanford University, Dr. Mignot has been a translational researcher since before it was fashionable. Besides being a medical doctor and a trained psychiatrist, his initial training was very rigorous in fundamental sciences and mathematics, having been selected as a student of the prestigious École Normale Supérieure and then subsequently conducting a PhD in molecular pharmacology. While mostly known for multidisciplinary work in narcolepsy, studies in his lab have ranged from clinical to basic. In collaboration with the Danish Technical University and the Stanford Biomedical Data Science Department, Dr. Mignot and colleagues are developing at-scale machine learning and rule-based routines for automatic analysis of thousands of PSG recordings. They have an effective machine learning routine for automatic scoring of periodic leg movements, sleep stages, K complexes, spindles, microarousals, and are working on sleep-disordered breathing events. They also derived a ML-based program that diagnoses narcolepsy based on sleep stage probability distributions observed during nocturnal sleep and have used similar models on large-scale proteomic data to estimate sleep apnea. Welcome, Dr. Mignot.
Thank you. Thank you so much. Can you, okay, show my screen. Hopefully you can see my screen. So it was very nice to have this presentation before me, because I think I'm going to try to put largely a lot of those things together. Because I think artificial intelligence is going to be applied not only in the study of sleep, but also to biological measures that could also be helpful to sleep. So, okay, I was trying to, I need to do that on the, okay. So I think what's exciting about sleep is that people may not realize is that I think we are really uniquely positioned to benefit from the revolutions that are going on in data analytics. I think I won't talk much, but there is definitely a revolution in the use of animal models. There is a revolution in genetics, which is almost done. I'm exaggerating, but now the genome is being sequenced and it's moving in full force. And I think Dr. Watson mentioned that very briefly. But there's a new revolution that's going to come about that's called in proteomics that I will talk a little bit about. The ability to measure proteins, many proteins at once in biological sample. And then there is a revolution in analytics, which I will mostly talk about because it will apply to machine learning. And then there's a revolution in hardware as well. I mean, we've heard a little bit about how Knox is now having increasingly easier way of measuring sleep at home. But I think this is even going to go even more into a simplified way of measuring sleep at home, but I won't be talking too much about this. So a few years ago, I started to think, what are really the main problems that the sleep field is facing? One of them was that it's very fragmented. So we have people from neurology, from psychiatry, from pulmonary medicine, from pediatrics, and we don't have a really homogeneous way of gathering clinical data on patients. And for this reason, I created kind of a questionnaire that assess sleep habits and subjective sleep symptoms for all sleep disorders. I kind of pull all the validated scales like the ASI, etc., together to create a questionnaire that we use in all our patients and that we can use to do machine learning on. We have more than 20,000 people now that have filled up this questionnaire. Then it was very clear that the sleep data is what we are getting. We are really throwing most of the data. We are only reporting sleep apnea index, AHI index, maybe a little bit of PLMI, but many people don't look at it even. REM sleep latency, it's all scored by human, but everything else we throw out. And as Dr. Watson mentioned, and as well as Jan, it's very clear that there is a lot more information in the signals that we are throwing out. So I thought we needed better analytics for PSG marker. Then I won't talk about it, but I really do think that there will be a shift from PSG to more simple ways of collecting sleep at home. And I do agree that EEG will remain a very important measure, but I will not be discussing that too much. And then finally, I think there is really a need for better biological markers, because I think if we had something like HB1C for diabetic, but instead for sleep apnea, I think maybe that would also change the way we assess our patients. So just for the questionnaires that we designed, we have designed a questionnaires that use branching logic. So basically, it's a questionnaires that ask questions, screening questions. For example, do you feel your leg are bothering you at night, etc.? And if they say yes, then it asks more questions. But if they say no, it moves to another section. And this way, we can really maximize the information we get from our patients, because at the end, it also creates like a summary measure of what the patient has been answering, and the clinician can look at a report that says, oh, this patient has a higher probability of having restless legs, sleep apnea. And I think it's very helpful, especially because nowadays we don't have a lot of time with our patients, and often we focus on sleep apnea, but we forget a lot about insomnia and restless leg and some of these other symptoms. And this way they are flagged automatically by the questionnaire that the patients are filling up even before seeing the doctor. But of course, the most important signals that we subject to machine learning or statistical analysis is really the PSG, which is an incredibly rich signal. And as I mentioned, I think we really don't use most of the information in the PSG. So the revolution really came about from indeed machine learning, but machine learning is a very broad term, as was mentioned. There is really deep learning and machine learning, and some of the machine learning can be glorified statistics, basically doing some kind of lasso or some kind of stepwise regression, but in a more sophisticated way. But that's really more statistics than machine learning. But often both are really used the same way. But there is a slightly different notion, which is called deep learning. Deep learning is a little bit different from machine learning in the sense that it's going to use usually convolutional neural networks. And these neural networks have really made a revolution in trying to find signal in very noisy inputs. For example, a picture actually is very noisy. I know it doesn't look like noisy because we're immediately able to recognize a face. But in fact, if you look at the pixels, most of the information is not about the face. And for this kind of information, machine learning, the subtype of machine learning called deep learning, has been really revolutionary. And the way it works is basically you have this little kind of neurons that have a decision tree, yes and no, based on filters that can be very simple or increasingly complex. And basically, the humans are going to look at all these pictures and are going to say, yes, this is a face, or it's not a face, or it's a face of Dr. Mignot or Dr. Watson. And little by little, the computer is going to learn each filter that is going to be the most predictive of a particular image. And amazingly, after a while, it can really recognize very faithfully the image of a dog or a cat, etc. This has really revolutionized completely facial recognition, for example, or speech recognition. And that's a way it works for this kind of very complex data. Then there's also two slightly different ways of looking at these deep learning models. Some of them are like convolutional networks, CNN, which are basically static. They analyze a picture and they look at each pixel with these filters, and then they have this gigantic tree that predicts if it's a face or not. And then there is a slightly different model where you try to add time information, and those can be, generally they're called recurrent neural network, or there's slightly a few different ones that are going to basically take the information instead of an image. It's basically a succession of image, and each time the machine learning program, the deep learning program is taking a decision, it's keeping in memory what it has seen before. And this is especially useful for sleep because, of course, when you score sleep, we look at the whole EEG. We don't look at just one snapshot we really look at how it progresses. If it's stage 1, we know it's going to progress to stage 2 or go back to stage 1. It's not random. So this way, the machine learning program, as it reads EEG, is going to keep in mind what it has seen just before to take the decision on the next sleep stage. And as was mentioned before, it's very important when you do this kind of machine learning, you transform the signal in some kind of picture that then is seen by this deep learning network. And then you have people who have scored stage 1, stage 2, stage 3, and little by little, the computer will learn all the pathway to decode this image to deduce the different sleep stages. But when you do that, it's very important to have both a learning set and then a completely new data set to make sure that the computer doesn't overfit the data. And that's really important. Any machine learning program, machine learning study, you should always have some kind of unseen data that the computer is going to be tested on after having learned. And as you see there, however, there are some techniques that allow the computer to learn without overfitting. And one of the ways, usually even when the computer learns, you leave aside a tiny bit of data that it's checking regularly to make sure that it doesn't overfit. So with a combination of these two things, which is basically a cross-validation where you basically check regularly with new data to make sure that the data is not overfitting, and also having a completely new data set, this type of deep learning can work extremely well. And as can be seen, and as was mentioned prior, what is also very nice about machine learning is it doesn't tell you just a binary response. It can give you a probability of a response. And a probability of a response gives you more confidence to the result. And when you compare the efficiency of a machine learning program, it's also very important to compare it not only to a single score, but to try to compare it with many, many scores. The reason is that this way you can show that the machine learning program can do better than a single score. So for example, here is one particular hypnogram, and white is wake, and then red is stage 1, light blue is stage 2, this is stage 3 and 4, and then dark is REM. And as you see, this has been scored by 5 different scores. And basically here, for example, is this 4 out of 5 scores that say it's REM sleep, and 1 score that says stage 2. Some people disagree. And you see here that most of the scores say wakefulness. And this way you can kind of have an idea of how the different scores, are agreeing on different on the sleep study. And what you see is very remarkable is the program doesn't only just tell you it's sleep or wake, it gives you what's called this hypnodensity. You can actually get a probability of each sleep stage. And you see that the probability amazingly match even the discrepancy of the scores. Like for example, here you see like some of the scores said it's stage 3 and others say it's stage 2. And the machine learning program is going to tell you, oh yes, it's mostly stage 2, but here it looks like it was the probability of stage 3 increased. So what is really remarkable about this machine learning program is that not only they give you a sleep stage, but they can also give you a probability of a sleep stage. How certain is a sleep stage? And that actually also generally correlates with how certain a large number of scores would be. And this is also interesting because, and that's machine learning, one of the things that people often criticize about machine learning or deep learning is they think that it's not very smart. It's basically imitating what a human is doing and doing nothing else. But in fact, when you think about the results, sometimes it gives you new ideas that can go beyond what even humans can do. So for example, what we noticed, and this was something also very important to remember, is a lot of people brand the notion of validation. They say, oh, this program is validated. I'm using this questionnaire that is validated. Always question what the validation means, because anything that's validated is only validated in the context it has been validated in. For example, if a machine learning program has been validated only in control, you have no idea how it's going to behave in dementia. And that's very important to remember that. And it's exactly the same for questionnaires. And when we started to study this probability of sleep stages in different pathologies, we actually found that all the pathology didn't make any difference in the automatic scoring with deep learning. Sleep apnea, insomnia, periodic leg movements, really the scoring of the different sleep stages with a machine learning program, the deep learning programs that I showed you, it didn't make a difference. However, for narcolepsy, there were a lot of dissociation between the control, what the scores were saying and what the machine learning program was saying. And we didn't really understand why, but when we plotted this hypnodensity graph, we quickly understood, because the problem may not be the machine learning program. It may also be the scores that have trouble really scoring these sleep stages in narcolepsy. But you see that in certain periods, first you see a narcoleptic may go into REM sleep very quickly, but also there were entire period of time where sometimes the sleep stages could not be recognized by the machine learning program. Here it says 30% probability of being stage 1, 30% wake, 30% REM sleep. But when you think about it, that's exactly what narcoleptics experience. Sometimes they are in this half states where they are half awake, half in REM sleep, and that's exactly what the machine learning recognize. And probably humans also have trouble because they see a muscle atonia, but the EEG looks like wake, and they just make a decision. But the truth is that the program recognizes that it's not normal sleep. And after that, we use, so that's using deep learning, but more like a regular statistics where you use lasso, or we extracted some of these probabilities in narcoleptics and controls, and we try to see if these weird patterns could then be used in more normal statistic like lasso to diagnose narcolepsy. And indeed, that's what was mentioned as a ROC curve. The closer, the smaller this interval, the higher is the diagnostic value. And as you see, it's incredibly good, so that you can almost diagnose all patients with narcolepsy very accurately just by studying sleep at night and using some features of REM sleep dissociation from this probability distribution of the automatic scoring. So it's just to show you that machine learning indeed imitates what humans do, but it can also be used to go beyond that if you add some other statistics and you use the information smartly. As was mentioned, machine learning is also very good, for example, at developing, detecting arousals. We have arousals is very often different scores don't agree, but with machine learning we can actually detect that better than individual scores. And again, you show that by really showing that the accuracy of a single score is below that of the machine learning program compared to a consensus of score. Right now we have pretty much studied all the modalities, and we really have, as you've seen, we have been able to do a sleep stage identification, which is probably the easiest, and it works better than humans. We also have been able to automatically score arousals, and I would say it works also better than humans. Now we have been working on breathing abnormalities and sleep apnea, which is the most important, of course, for all of you. And I have to say that this has been quite hard. And one of the main reasons is that scores are pretty abominous at agreeing on scoring sleep apnea. And when you have a bad gold standard, it's very difficult for the computer to imitate something that even the scores don't agree on. To give you an idea, there's a paper that was recently published where there were 2 scores from Stanford, 2 scores from UPenn, 2 scores from Harvard, and 2 scores from St. Louis. And they scored 70 studies. And out of 70,000 events that were scored as sleep apnea, only 30,000 were scored by at least 2 scores. So it shows you that the scores really don't agree. And half of the events were scored by only 1 score. So when the agreement is so poor, it's very difficult to actually design a good machine learning program. I'm not going to go in detail because we're still working on it, but we think that we have found some solution. And as was mentioned by Nat, what is interesting is definitely the EEG is very important. To distinguish the different subtypes of breathing abnormalities. but we also have suggestions that there are also some breathing abnormalities without arousal. So maybe the way we really classify sleep disorder breathing maybe should be thought slightly differently. Otherwise, I would say that this worked really, really well for pretty much every event that we're currently scoring. And our goal is really to use it in conjunction to genetics, because the beauty of genetics is that it's really giving you the cause of things. Genetics doesn't change with the environment. And as a consequence, when you have, for example, for narcolepsy, if you do a genetic screen of you look at all the genes that are associated with narcolepsy, you find that they are all related to the immune system. So you know that it's an autoimmune disease. It really get at the cause of things. So if we could find genes that are associated with sleep disorders, it really gives you an idea of the pathways that are causing actually sleep problems, not just a consequence of sleep problems. And what is very interesting, and I'm not going to be too long on this, but is that it's actually changing a lot of the way we are looking at some sleep disorders. For example, it looks like insomnia and restless leg are sharing a lot of genes together. And that was a little bit of a surprise. And that it looks like long sleep or hypersomnia is sharing a lot of genes with schizophrenia or bipolar disorder. We knew that bipolar disorder patients often had complaint of hypersomnia, but this seems to be evidence in population studies. So I think some of the way we look at even sleep disorders may have to change. Maybe RLS is a combination of several pathology, maybe insomnia together with some leg movement like pathology. And by trying to look at the different genes that are associated with different traits, I think we might be able to understand better what is really the true disorder and which gene predisposed to which facet of a sleep disorder. So the last part of my talk, is only a few slides, is about proteomics. So I told you about genetics. The beauty of genetics is that it is really potentially giving you the cause of the problem, because unlike in the blood, if you measure cholesterol, it's going to change with what you eat and your genetics. But if you cannot change your genetics based on what you eat. However, the cholesterol is still what's the most important for the disease. So really what you want is to be able to measure things maybe in blood that are really modulated by the genes and cause disease. And if you do that, you can actually find things that are actually causal. This concept is a concept that's called Mendelian randomization. For example, levels of cholesterol we know are very important for disease. And if you do a screen of heart attacks and so forth, you are going to find genes that regulate the levels of cholesterol and that regulates the risk of heart attack. And the advantage is, because of that, you know that it's causal. You know that the genes are changing the genotype and that are changing the cholesterol levels that are changing the disease. So you know that if you change the cholesterol level, you're going to change the disease. At the opposite, if you had something that's just caused by the disease, it wouldn't be linked to the genes. For example, when you are sleep deprived, a lot of things can change, but they might be the consequence of sleep deprivation, and they are not interesting. They're just biomarkers of sleep deprivation, but they are not causal. But if you link them to the gene at the same time, you know that they're causal and they could be drug target. So one of the things we have been really trying very hard, and we've been using machine learning in this area, is to use proteomics. And now proteomics, I like to say it's a little bit like cold fusion, like fusion. We have heard for 20 years or 40 years maybe that it's going to be solved, that soon we'll have electricity for free, and that we won't need fuel to power a house, but we have been still waiting. And proteomics is a little bit the same. For many, many years, people have said, oh, we'll be able to measure thousands and thousands of proteins in the blood, and then that would change a lot medicine. That would be doing the equivalent of the genetics, but for body constituents that are circulating in the blood. But until recently, it was just not working. But very recently, there are new methods that makes it possible to measure thousands of different proteins in the blood with even 100 microliter. I use a particular platform that's called SomaLogic, where they can measure 5,000 500 protein at once with 100 microliter. And when you start to look at this, you know, it's a completely different picture of health that you see. Because instead of just looking at one biomarker for one thing, you look at thousands of biomarkers at once. So for example, if you're interested in kidney disease, we all look at creatinine, but creatinine is not a perfect marker of kidney disease. You know that creatinine depends also of muscle mass. But when you measure 5,500 protein, you find 500 protein that varies depending of glomerular filtration. Some are also a little bit influenced by exercise or by other things, but globally, they are, as a multivariate model, they are much more predictive of glomerular filtration than a single measure, which is confounded by more things. So I think our biomarkers are going to move away from measuring a single thing to measuring a large number of things and doing mathematical modeling to predict certain physiology. And for example, it's perfect for circadian biology, because circadian biology, you know that there are a lot of things that vary depending of circadian phase. And here we had people in constant routine, and we measure this 5,500 protein, and you see that we can find very easily protein that really peaks at every time of the day, even when people don't sleep. So independently of sleep, it's purely circadian. And some of them make sense, like one of them is cortisol, ACTH, which we know peaks in the morning. Others are very interesting, like PGD2 synthetase. It seems to peak in the middle of the night. We know it's kind of a sleep promoting agent. But the nice thing is if you measure all these things at once, when you know that some are high and some are low, you can actually deduce the circadian time of people. So now we can actually, with one sample of blood, we can tell if people live in Tokyo time or have delayed sleep phase. And I think that's going to change a lot medicine, because we don't really understand hypersomnia, for example. And we are starting to have biomarkers also sleep deprivation. So by doing this kind of complex modeling, we may be able to predict, oh, this person only sleeps 5 hours a night. So the problem is he's tired because he doesn't sleep enough. So this is just to, and again, this is using this kind of models of machine learning to try to predict this data because it's becoming very complex. So I think there is a real revolution. And what I'm hoping is that with linking the proteomics, the genetics, and the sleep biomarkers with the EEG, we're going to be able to really create a sleep clinic of the future, where we will have blood biomarkers that can predict certain sleep disorders, maybe sleep debt and internal sleep circadian clock. Maybe we will measure much better sleep even at home with new devices, and be able to score not only regular sleep stages, but predict certain disorders. And I think hopefully some of that will translate into better patient care. So I just want to mention my people in my lab and the main people who have been working on the data I've presented. Thank you so much.
Thank you, Dr. Mignot, for a revealing and fascinating presentation. Just a reminder that a PDF of the slide deck is available in the handout section of your control panel, and this webinar is being recorded. You will get a follow-up email tomorrow around this time, and that will include a link to the recording. And we are about to do some questions, but I also want to remind you, be sure to take the course evaluation, which will appear on your screen after the webinar ends, or once you click out of it. Let's do our first audience question. Dr. Watson, I will ask you this one first. How do you see us using AI to improve therapeutic compliance and health outcomes?
Yes, thank you for that question. And these talks were really great, and I learned a lot as well here. You know, I think that all of this work is really leading towards the notion of really sub-phenotyping people with sleep disorders in order to tailor therapies for individuals. For instance, not every patient with insomnia is the same. And as we know clinically, not every patient with insomnia responds the same way to any given medication. And yet we may trial multiple medications to ultimately find the one that works the best. And so I'm hopeful that, a lot of things that Jan Emmanuel talked about will come to fruition, where will allow allow us to understand our patients better and tailor therapies more specifically so that we can get right to the thing that works best first and quickest in order to help the patient.
Excellent. Dr. Augustin, let me ask you this question. Is there a standardized AI analysis pipeline yet, or will findings vary across research, practice, software vendor?
Yeah, so there's no standardized methods or standardized data sets or anything like this. And I think this poses a bit of a challenge, and even making a standard would be very complicated. The question about the variance is that, of course, there will be variance between research groups and industries and different companies, and everyone will have a slightly different results. But this is also true with humans. Like Emmanuel Mignon mentioned, that you score 70,000 apnea events, and only 30,000 are scored by more than one person. So I think variance is something which is, even with humans, for example, I thought about this, having a standardized like validation test data set that everyone could compare their analysis against. I think this would be great if it would be possible, but I think in reality what would happen is that people would start overfitting to the validation data set, even though if they don't know it, they would start using methods and stop when they have something which works good on this data set. And they might not work very well in reality because they would just be fitting to that data set. So it's a challenge, but there's nothing standardized yet.
If I may, Sri, I would suggest too, it seems like there's an emerging marketplace out there that, for people that are getting into this. And so some level of standardization is going to be important. And if you look at position the AASM, they do comments about, AI systems need to detail the population upon which it's based, how they addressed artifacts, sampling rates and settings for digital acquisition and analysis, and also data dictionary. Now that might be the low-hanging kind of first things that we would suggest that the Academy is beginning to look at ways to try to standardize a little bit going forward.
I actually have another suggestion, Nat, that I've been seeing because I've had discussion with the FDA, and it's interesting. But you know what I think I would do, actually? I would be a bit even harder. I would do exams for the machine learning programs. It's basically you just provide some data, and then you have the people test it. So this way, that would be an interesting thing that maybe even the academy could do. I mean, the same way as we take an exam, you would say if someone has a machine learning program, they ask the academy to provide the data and to send back the results, and then the academy will certify or whatever that this is working on a new data set that has never been seen. I think we may come to something like this. I mean, with the FDA, I think that's a way they should probably do it. I don't know if that's the way it will be done, but I agree also that we need a common data set still. The other thing that's very important is to have diverse data set. I forgot to mention that, but in all our machine learning program, we really try to use PSGs from many, many, many different sources, because we want to make sure that the program doesn't learn things from very, very specific setting. So we use PSG from China, from Europe, from maybe 20 or 30 different sites to make sure that the program doesn't recognize features that are only present in certain setup. Of course, that has a disadvantage of losing some information. For example, I'm sure that Knox would love that, but if we were all using Knox, we probably could do slightly better, because they have certain features that are not going to transfer to other systems that may not have the same level of quality, for example. So it's a very complex program, but I really think that we should make available some data set that are diverse. And all our programs that we write are on GitHub, so people can use them and try them. And also, we have shared a number of PSGs already that people can use. And of course, there is a National Sleep Research Registry that has a lot of PSGs that can be used. So I think there is quite a bit of data, but I agree that we're missing some kind of data that's very diverse and could be used by everyone as a comparator.
Dr. Mignot, considering the power of AI, where do you see the future tasks of the sleep technicians?
I think there is always more, because I mean, there's two ways of looking at things. Either you're afraid of the future and you get troubled by it, or you embrace it and then it can be fun. And I really see that there will always be more technology, more, for example, the sensors that we use, they're extremely diverse already. I know we would all like to use the same sensors, but it's not going to be the case. I mean, there will be more and more slightly different platform sensors. Maybe there will be some hardware that will be used at home that you will need to understand, to recognize. So I'm not so worried about the role of technicians. I think it's just going to change. The most boring part, which is just to score, is going to probably be decreased significantly, because technician maybe will only look at the parts that are not so clear. So I think the job of a technician will become more interesting, but I really don't think it will disappear. Because we have to realize that most people with sleep problem are not being studied. So there's so many patients that need to be studied that I think there will be more work. But that's just my general opinion.
If I maybe, I would also say that I envision technologists coming more into the clinic and spending their time helping patients, acclimate to PAP therapy or address adherence-related issues in order to improve outcomes. So I envision the job evolving over time in ways that will impact directly upon patient care.
Dr. Augustin, during your presentation, when you were discussing arousals, one attendee wanted to know if you might be able to clarify what arousal meant in that study.
Oh, I think probably Nate and Emmanuel are better qualified to clarify that, because I'm just a physicist. But I think the definition is that an arousal is an abrupt change in the EEG frequency around 16 hertz or something like this, following 10 seconds of stable sleep. Am I correct?
Yes, it's a change. Even so, the REM sleep is slightly differently defined. So this is actually a good question to raise in general, because that's the advantage of deep learning. When I started to work on this field, I tried to create what we call rule-based detectors, which I think a lot of people tried as well, is you try to create these rules that are based on the ESM. For example, you say, oh yes, if the EEG needs to go faster in frequency, or you need a change in EMG or whatever, and then you try to recapitulate these changes by analyzing your signal. It actually doesn't work well when you do that. The problem is that humans are incredibly good at detecting artifacts. If you say, for example, the EEG needs to go faster, but suddenly you would have a 60 hertz, kind of contamination. I'm just, a computer, if you just tell him if the EEG, if the frequency has to go faster, it has to be an arousal for at least 3 seconds, it's going to do it because it can recognize it. But a technician can immediately recognize it and will not even think it's an arousal. And the beauty of deep learning is because it's based on annotation by technician, it's really learning to imitate a human. So actually the rules that it takes are immaterial. They are much closer to what a human does than what artificial rules that even the ESM would give, because nobody follows exactly the ESM rule. We interpret them every day in slightly different ways in reading our sleep study using our human intelligence. And so in general, the definition, of course, that is used for those arousals was, the one of the ESM, but it's the way a human is interpreting these rules. And I think a human doesn't exactly follow the rules. I don't know if it's answering your question.
I think it did. Thank you very much. Well, I'm sure we could talk about artificial intelligence all day, but unfortunately, it's probably about time to wrap up. Thank you to the hundreds of audience members who are still on today's call. And of course, I want to thank our three presenters and as well as our sponsors, Enso Data and Knox Medical. You can email me at sroy@medcore.com with comments, questions, and future webinar suggestions. Or if you watched the live event today for at least 60 minutes, but you didn't receive your certificate within 30 days, we do keep your unanswered questions on hand for future articles for Sleep Review magazine and pass them along to the sponsors who sometimes have contacts who can answer those. Visit us at www.sleepreviewmag.com, and thank you so much for participating in the Sleep Review webinar.
Thank you, everyone.
Thanks, everyone.
Thank you, everyone.